So is your visa and everything is processed? Or? I don't know, it's a public forum, so probably we should not talk about it.
No, that's fine. But yeah, luckily I don't need one, so we're good.
So you can see the shared screen?
Yes, doctor, I can see the share screen.
So I think we'll start. So now you may start recording.
Okay, yes, thank you, sir. Okay, so now it's recording.
Yes. So dear all, Assalamualaikum, Ramadan Kareem. And probably this is the last or the second last lecture that you're getting. I'm sorry for this late afternoon lecture. During the session, as you know, if you have any questions, just unmute yourself and ask the question. If I'm asking something, just unmute yourself and answer the question. Don't write in the chat because I won't be following chat. So just unmute yourself and say whatever you want to say. It's just like when somebody's talking, so then the other person should wait. Okay, so let's start. So today we are going to talk about drugs used in the treatment of glaucoma. And these slides are taken from and slightly updated from Dr. Dilip's presentation given last year with his kind permission. So it's almost the same slide with slight updates. So our learning objectives today first is to review the synthesis of aqueous humor because see as you know, whenever we talk about pharmacology, we always review physiology and a little bit of anatomy relevant so as to know that where these drugs are going to work. So we need to know our targets and how they are going to produce their effects. So again, we need to understand the physiology. So here we will be reviewing the synthesis of aqueous humor. And we'll define glaucoma and we'll discuss its various types. And then we'll classify the drugs used in the treatment of glaucoma. And we will correlate the mechanism of action of these different categories of drugs which are used. And we'll discuss their adverse effects and contraindications. Okay. I hope this thing that shows up as admit and these things will not show up in recording. Like, is it showing up on the student's screen? I hope it's not hindering their view.
Doctor, there's nothing, like we can see the cursor and the screen, nothing else. Good. And like your presentation.
And you are admitting the newcomers, huh?
Yes, I am.
Because you made me also showing up on my screen as well. So let's talk about glaucoma. So you guys have done glaucoma in your physiology lecture and I think in your clinical lecture as well. So what is glaucoma? Dear students.
Please, you guys, raise your hands if you have an answer.
Yeah, I'll just unmute yourself and speak.
I think it's raised intraocular pressure as a result of the aqueous humor production.
Can you be a little louder?
I mean, it's an increase in the intraocular pressure.
Okay.
And also, I believe it's damage to the optic nerve because of increase in intraoptic or intraorbital pressure.
Very good. So damage to the optic nerve is more important. Raised intraocular pressure may not be there in some cases. So yes, so that's the definition. So glaucoma is a group of eye diseases characterized by damage to the optic nerve, usually due to excessive high intraocular pressure caused by aqueous humor. Okay. So most of the cases, they have high intraocular pressure as well, which leads to optic neuropathy or optic nerve damage, which has characteristic appearance. I hope you have done it in your clinical lecture, that like this, the cupping of the disc and the cup to disc ratio. Are you familiar with that? So see, all the axons from the retina, they are gathering together at the optic disc, and that's where the optic nerve forms. Because of the pressure, the ischemia of the axons, and they start dying. So because the optic nerve or the disc at the is being made from those fibers. So if there's ischemia of those fibers, so then there's atrophy of the optic disc, and there will be cupping, and the cup to disc ratio will change. Have you done that in your clinical lecture?
Yes.
Yeah. So that's, and obviously then with that there will be loss of vision. So gradual or sudden loss of vision, which will start from periphery and then will go towards center. So that happens usually due to excessive high intraocular pressure, okay? And that happens because of aqueous humor. But in some, so commonly associated with elevated intraocular pressure, but in some cases it can happen with normal intraocular pressure as well. So patients can have typical neuropathy and optic nerve damage and loss of vision, which happens in glaucoma, but the intraocular pressure is normal. Now that pathophysiology is slightly different. I won't go into that, but probably those people are more sensitive to pressure changes, and they are developing the changes even in the normal intraocular pressure. But in most of the cases, it is because of high intraocular pressure. So when we speak of pharmacotherapy, we usually talk about glaucoma in the context of elevated intraocular pressure. And in any case, our target is to lower the intraocular pressure. So whenever we speak of pharmacotherapy or even laser or surgical therapy, the target is to lower the intraocular pressure. Okay. So what is the difference between ocular hypertension and glaucoma? So ocular hypertension is just the raised intraocular pressure without optic nerve or optic disc damage. So no loss of visual field. So no visual problems, no visual field problem, no optic nerve problems. It's just raised intraocular pressure. So that's ocular hypertension. But in glaucoma, there is associated, there is optic nerve damage with or without raised intraocular pressure. So a disease with or without clear rises in the intraocular pressure above the normal range, but it is definitely accompanied by a progressive optic neuropathy leading to a slow progressive loss of vision. That is blindness. The chronic wide-angle glaucoma is, I think, worldwide #2 cause of blindness. So it's a very common cause and treatable and I would say preventable cause of blindness. If it is detected in time, it can be prevented. And that's why the screening and the pharmacotherapy are important. Now let's talk about aqueous humor dynamics. Now, I hope you're familiar with the anatomy part. So let me change the cursor. So the aqueous humor is produced. Where is aqueous humor produced?
Ciliary body.
Yes, it's produced in the ciliary body. Good. By the epithelium of the ciliary body. And then where does it go?
Posterior chamber.
It's being produced in the posterior. Yeah, so it is first it's produced in the posterior chamber from the ciliary body. And so obviously it comes into the posterior chamber. And then from posterior chamber, this is posterior chamber. Behind the iris and in front of the lens and behind the iris. So this area is the posterior chamber.
Yes.
We are not talking about the vitreous chamber. We are not talking about the vitreous cavity.
Yes, it passes through from the posterior chamber through the pupil into the anterior chamber.
Yes, very good. So it flows from the posterior chamber through the pupil into the anterior chamber. And then where does it go? Where does it
Can
go?
I ask him?
It drains through
Yes.
the trabecular meshwork.
Yes, so very good. So it is drained mainly through the trabecular meshwork into the canal of Schlemm. So here you have trabecular meshwork, and this is the canal of Schlemm, and it goes into the venous system. And this is the major drainage pathway. But we have a very minor drainage pathway, which in normal physiological situations contributes less than 10% to the drainage, which is uveoscleral pathway. But this pathway can be very important when it comes to disease states, because this can be exploited by pharmacotherapy, and this can become a good drainage pathway. So keep this in mind, uveoscleral pathway. Okay, good. So aqueous humor dynamics. Let's start. So it's continuously produced by the ciliary body at a rate of 2 to 3 microliter per minute, and it flows from posterior chamber through pupil into the anterior chamber. It drains out from the eye into the venous circulation via trabecular meshwork, canal of Schlemm, and uveoscleral outflow pathway. Types of glaucoma. How many types of glaucoma are there?
2.
Okay, which are?
The closed angle and the open angle glaucoma.
Good. So, as you said, so angle, when you say angle, so which angle are you talking about?
The angle between cornea and the iris.
Yes, so there's an angle formed between cornea and iris. So in a situation where, because see at the angle of it, we have trabecular meshwork and canal of Schlemm. So this is the drainage pathway. So if this angle gets closed due to certain reasons, suppose if it is being pushed, the iris is being pushed forward, and this angle gets closed. So this can be due to various reasons. It depends on the axial length of the eyeball may be smaller. There may be some other anatomical variations. There may be lens bulging. So anything which bulges, so there can be anatomical problems. There can be some due to some trauma or something. If there is hematoma here. So whatever reason, if the iris gets bulged forward and the anterior chamber becomes shallow, and sometimes anatomically anterior chamber can be shallow. So some people have anatomy where they are at a higher risk of closed angle. So and that can again be assessed. So due to various reasons, if this iris gets pushed against the cornea and its angle gets closed, so the drainage pathway gets closed. So now the aqueous humor is being formed, but is not able to drain, and that's how it builds up the pressure in this aqueous chamber, and that gets transmitted into the vitreous chamber as well, and then pushes on the retinal fibers as well. So and that leads to optic neuropathy. Now then there can be another situation. In some situations, see again when the pupil is in the mid-dilated position, sometimes this iris can get stuck with the lens, and even the aqueous humor is not able to go beyond the posterior chamber. So this is called pupillary block. Again, this will lead to the same thing. So there can be a closed angle, and then there can be this pupillary block as well, and they can happen together as well. So this is all part of the pathophysiology of closed angle glaucoma. Now, usually it develops acutely in patients. It develops acutely, so we call it acute closed angle glaucoma, or acute angle closure glaucoma, or some people also call it narrow angle glaucoma, acute narrow angle glaucoma. If it develops acutely, usually this presents acutely. This develops over a period of hours, sometimes days, and presents with, do you know the presentation of acute angle glaucoma, acute closed angle glaucoma? How does it present? Hello? How acute closed angle glaucoma presents? Any idea? What are the signs and symptoms? Please unmute and speak. Not following chat.
If you guys know, can you please raise your hands?
Someone is saying pain, radish. I'm saying don't write in the chat, just unmute and say it. See, you guys are responding in the chat. I'm not following chat. I just had a look at the chat.
Mid-dilated pupil.
Yeah, so on examination, you will see mid-dilated pupil. But as someone said, redness or red eye, will there be pain? Is it a painful condition?
Pain,
Yes.
headache, nausea, and vomiting.
Yeah, so it usually presents with pain. That's the main presenting feature. So severe pain in the eye as well as a headache associated with nausea and vomiting. And then will there be some other blurring of vision or some halos around the light? Have you done the clinical presentation of glaucoma? Yeah, so this cornea will be cloudy, the eye will be quite firm or hard on palpation. When you on examination, the intraocular pressure will be raised, the conjunctiva will be red or injected. So there are many features. You should be familiar with the clinical features of this, because this is acute presentation. Presents an emergency, and is it an emergency? Please speak. Are they allowed to unmute themselves?
Yes, they can unmute themselves. You guys, please, instead of writing in the chat, just unmute yourselves and speak.
So this is an emergency, and you need to treat it in an emergency. Otherwise, one can lose the vision, eyesight. Okay. So we spoke about and opposed to that. So these people who are prone to develop closed angle, they may be like hypermetropic, while the people who develop open angle, they may be myopic. So this is another risk factor for these things. So open angle, again, as you can see, so the angle between the iris and cornea is wide open. So that's why we call it open angle glaucoma. So now the question is, if the angle is open, then what is the problem? If the angle is open and if the aqueous humor is able to flow from the posterior chamber to the anterior chamber, then where is the problem?
The trabecular meshwork.
Yes,
Or
trabecular meshwork, yes.
maybe increasing the production of the aqueous humor.
Yeah, but it's more a problem of the trabecular meshwork because of aging and some genetic problems and other associated diseases. So there may be hypertrophy of the extracellular matrix, which kind of clogs the trabecular meshwork. So the drainage system gets clogged here. So it's again not able to, though the angle is open, but the meshwork is clogged. And that's why it's not able to drain. But the angle is open. So this develops gradually. So that's why there's not pain. So it's asymptomatic, but because of this gradual increase in intraocular pressure, there is optic neuropathy. So there is loss of vision. Usually it starts from the peripheral loss of vision. And that's why the screening is very important in the high-risk patients, because if you don't detect it on time, because once there's optic neuropathy, the loss of vision is not reversible. Whatever somebody lost is lost. You can prevent the further damage, but whatever visual field is lost is gone. So that's why timely diagnosis and the normalization of intraocular pressure is very important. Okay, I think enough of the review of pathophysiology. Let's go into the drugs. So again, before going to that, the role of autonomic nervous system in the eye. I'll go through it quickly. So pupil is controlled by both sympathetic nervous system and parasympathetic nervous system. So what is the role of sympathetic nervous system on the pupil? Quickly, somebody.
To constrict the pupil.
Yes, and parasympathetic. Yes, sympathetic nervous system dilates and parasympathetic nervous system constricts. So sympathetic nervous system stimulates the Dilator pupillary muscle leads to dilatation of the pupil. Parasympathetic nervous system stimulates the sphincter pupillary muscle, and that's why it constricts the pupil. The ciliary body is controlled also again by both sympathetic nervous system, parasympathetic nervous system, but they are not opposing effects. Like on the pupil, they are opposing effects, but here they are not opposing effects. Sympathetic nervous system, both beta 1 and beta 2 stimulation increases the aqueous production. Keep in mind. So both beta 1 and beta 2 stimulation increases the aqueous production. That's the role of sympathetic nervous system. So, okay, so catechola means epinephrine, norepinephrine, they increase the synthesis of aqueous humor. Okay. While the parasympathetic nervous system has a role on the ciliary body muscle movement. And that again has a role in the drainage and all those things, which we will come to later. So it's an entirely different role. Okay, clear? So how do we treat glaucoma? So we have two strategies. Either we can increase the drainage or outflow of the aqueous humor, or we can reduce the production of aqueous humor. Because we need to reduce the intraocular pressure, and that we can do by reducing the aqueous humor present in the anterior and posterior chamber. And that we can do either by enhancing the outflow or by decreasing the production. Okay. And we do it through many drugs, and then we have laser therapy and surgical interventions. So drugs which enhance the drainage or outflow of aqueous humor. We have three categories. We have cholinergic agonists, pilocarpine and ecothiopate, which you have done in POD block. So you are familiar with them. We have prostaglandins, which I am not sure. Have you done these in your POD block? Yes, you keep saying no in the chat, but like you don't speak up. Okay. So you have latanoprost, bimetoprost, travoprost. So again, see, it's very easy to remember the names. You guys were worried about the number of drugs. So prost, you know it's a prostaglandin. Latanoprost. So wherever you see the name like latanoprost, travoprost, or bimetoprost, so you know it's a prostaglandin. Okay, but for the exam purpose, you may, if you want, you may forget bimetoprost. Okay. So anything which is dimmed, if you don't want to remember the name, it's okay. But it's very easy to remember these names. The third category, which is a newer agent, is Rho kinase inhibitor, netersudil. So we have these three categories which increase or enhance the drainage of aqueous humor, the outflow of aqueous humor through different ways. We will go into details. Then we have another three categories which decrease the production of aqueous humor. And as you know, as we said, sympathetic nervous system, both beta 1 and beta 2 stimulate the production of aqueous humor. So it is very logical to give beta blockers. So we have beta blockers, very commonly used drugs, and they decrease the production of aqueous humor. They are commonly used in both open angle as well as closed angle. Open angle is also known as wide angle, and closed angle is also known as narrow angle. Okay. Okay. So beta blockers, timolol is the most commonly used drug. It's non-selective. Again, all these drugs which you're talking about are the topical uses. Like in the form of drops, we put drops in the eye. So these are topical drugs. Levobinolol, and then we have two more drugs, which if you want, you can forget about them. Then we have betoxolol. But again, see, all these drugs are ending in olol. Okay. So anything which you see OL in the end, you know it's a beta blocker. Then we have alpha-2 adrenergic agonists, apraclonidine and brimonidine. Again, the end is onidine. These are alpha-2 adrenergic agonists. Again, you have done these beta blockers, alpha-2 adrenergic agonists in your POD block. So you are familiar with these drugs. It's just like they are another clinical use. That's what you're doing. But you have done this, their mode of action, their side effects you already covered. You understand the autonomic nervous system and their drugs. And then we have carbonic anhydrase inhibitors. These drugs you will do in the renal block. Probably you did a little bit about them in your first year renal block, but you'll do in details in your third year renal block. But here we'll talk about them a little bit. So we have dorzolamide, benzolamide, acetazolamide. So again, they are ending with zolamide, carbonic anhydrase inhibitors. Okay. So let's go into the details. So let's start with the drugs which these were the drugs which were decreasing the production. So let's start with the drugs which increase the drainage or outflow of the aqueous humor. The first class was cholinergic agonists, and the two drugs that we'll talk about are pilocarpine and ecothiopate. Okay, and again you have done these drugs. So can you tell me, these are cholinergic agonists. So what is the difference between pilocarpine and ecothiopate? Please somebody speak up. The difference between pilocarpine and ecothiopate in their mode of action. What is the difference?
One is direct, one is indirect.
Good. Which one is direct?
Pleocarpine.
Yes. So pilocarpine is a direct acting muscarinic agonist, while the ecothiopate is an indirect because it doesn't work on the receptors. Pilocarpine works on the muscarinic receptor, so it's muscarinic agonist, a cholinergic agonist. So it's direct acting. Ecothiopate is acetylcholine esterase inhibitor. So it increases the acetylcholine concentration in the synaptic cleft. So it increases the effect of acetylcholine. So that's how it's indirect agonist. Okay, is that clear? And as you know, these are parasympathetic. So their one action will be on the iris muscles. So it will stimulate the sphincter pupillae muscle and will lead to meiosis. Because cholinergic agonist, it will lead to meiosis by causing the contraction of the sphincter pupillae muscle. Okay, is that clear?
Doctor, can you explain why ecothiopate is indirect acting?
It's indirect because it's not acting on any receptor. It's inhibiting an enzyme, acetylcholine esterase enzyme. The role of the acetylcholine esterase enzyme is to degrade the acetylcholine present in the synaptic cleft. Acetylcholine also stimulates the muscarinic receptors, same as pilocarpine is doing. Okay. So, but it's naturally degraded by the acetylcholine esterase enzyme. Now, this ecothiopate inhibits the acetylcholine esterase enzyme, and that's why the concentration of acetylcholine remains higher for a little more time than usual. So you have enhanced acetylcholine effect, same as pilocarpine. So it's an indirect muscarinic agonist. So it's not directly acting on the receptor, it's indirectly increasing the concentration of acetylcholine in the synaptic cleft. Is that clear?
Yes, doctor. Thank you.
Okay. And both of these drugs will cause meiosis by causing contraction of the iris sphincter muscle or sphincter pupillae muscle. Okay. What will this do? This will pull the peripheral iris away from the trabecular meshwork, and that will open the angle. So what will this do? This will pull the peripheral iris muscle away from the trabecular meshwork, and that will lead to opening of the angle. So this will pull this muscle a little bit away from the angle, and that will lead to opening of this angle and the increased drainage of the aqueous humor. And we have angle problem in which case? In acute angle closure glaucoma. So this effect will help us in the angle closure glaucoma. But at the same time, we said the parasympathetic nervous system has a role in the ciliary body as well. So it causes the contraction, let me go back here. So the first thing that we talked about, so the meiosis or contraction of the sphincter pupillary muscle, this opens the fluid pathway and because it pulls the iris away from the angle. So it opens the fluid pathway and facilitates drainage of the aqueous humor into the canal of Schlemm and drainage, decreasing the intraocular pressure. So this is beneficial for angle closure glaucoma. Also, the contraction of the ciliary muscle fibers, which insert in the trabecular meshwork, cause an increase in the meshwork pore size, facilitating the aqueous humor flow. This effect is beneficial in open angle glaucoma. So because of the contraction of the ciliary muscle fibers, there's a pull on the trabecular meshwork and that their pore size increases, and that leads to increased drainage, and that's beneficial in open angle glaucoma. Okay. So its uses, so it can be used both in open angle glaucoma as well as in the short-term management of acute angle closure glaucoma, but again, we don't use it on a chronic basis because you have to give it multiple times a day, and it has side effects as well. So adverse effects: pupil constriction, induced myopia, because when the ciliary muscle contracts, the lens becomes more convex, and that's how it focuses on the closer objects. So induced myopia, and that's why it leads to blurred vision. And it can also lead to, see, if you're giving it frequently and consistently, so it will lead to ciliary spasm, which causes the lens and vitreous to move forward, and it will lead to retinal tear and retinal detachment. So that's why, so because of these side effects, it's not your first choice when it comes to, especially when it comes to open angle glaucoma management. So we have other options. In closed angle, in emergencies, again, not the first drug, but yes, it is used, and it has very beneficial use in that situation. And obviously the local effects, irritation, lacrimation. Now let's talk about another class of drugs, prostaglandins, which again increase the drainage of the aqueous humor. Prostaglandins, these are F2 analogs, which are latanoprost, bimatoprost, travoprost. So again, latanoprost is the prototype drug, very commonly used. Similarly, travoprost is also very commonly used. If you want, you might forget about bimatoprost. Okay, and these are very unique and beneficial. How do they work? Prostaglandins lower intraocular pressure by increasing uveo-scleral outflow. Remember, we talked about uveo-scleral pathway, which is in physiological stress very minor. But what can we do in disease states? We can exploit that pathway with drugs. So uveo-scleral outflow passes through extracellular spaces within the ciliary muscle. So we need to create more space into the extracellular, we need to create more space in that extracellular space region. So we need to degrade the extracellular matrix. Activation of prostaglandin receptors stimulates increased biosynthesis of matrix metalloproteinases. So these matrix metalloproteinases, these are family of neutral proteinases, and they cleave extracellular matrix molecules. And which is a very common molecule? Collagen. So these MMPs may initiate the alteration of collagens in the ciliary muscle to increase spaces among ciliary muscle fibers, thereby reducing hydraulic resistance to the uveo-scleral outflow pathway. So what are prostaglandins doing? Can someone tell me?
They change the collagen within the ciliary muscle, so therefore there will be more spaces for the drainage.
Yeah, in this uveo-scleral pathway.
Yes, in the uveo-scleral pathway.
Yeah, so. And they have very limited side effects, so they are primarily used in the open angle glaucoma. So primary open angle glaucoma is the main use, because this is again not an immediate effect. It takes time, so it doesn't have much role in the acute close angle glaucoma, but in open angle glaucoma, this is your like first choice that you use. You can also use it in ocular hypertension without glaucoma. Adverse effects, there are very systemic adverse effects are rare, but however, we have some local and cosmetic effects like conjunctival hyperemia, iris pigmentation, periorbital darkening, eyelash glowing, thickening, and darkening. So that was prostaglandins. Now another drug, which is netrosudil, and this is relatively newer, but like again, it's been like 3-4 years now. Now, to talk about this drug, you need to know there are Rho kinases. These are serine threonine kinases that function as important downstream effectors of Rho GTPase. Such activity in trabecular meshwork and Schillem's canal drives ectomyosin contraction, promotes extracellular matrix production, and increases cell stiffness. So if you inhibit Rho kinase, so netrosudil is an inhibitor of Rho kinase. So if you inhibit Rho kinases, so all these things that like this ectomyosin contraction, production of the extracellular matrix, and cellular stiffness, these all will be inhibited. So inhibition of Rho kinases will reduce cell contraction, decreases the expression of fibrosis-related proteins, and reduces cell stiffness in trabecular meshwork and Schillem's canal. Okay. So these actions result in increase in trabecular outflow facility, leading to increases in the effective filtration area for the trabecular meshwork. So this again facilitates the outflow or drainage of aqueous humor.
Doctor, can you explain how it decreases the expression of fibrosis-related protein?
Because the Rho kinases are increasing promoting the production of fibrosis-related proteins. So if you're inhibiting Rho kinases, so that's how they decrease the expression of fibrosis-related proteins. Because it says promotes extracellular matrix production. Again, we have collagen.
Oh, okay.
Okay. So that's how it reduces extracellular matrix production and fibrosis-related proteins. So it provides more filtration area. Okay. So we talked about 3 classes. We have cholinergic agonists, we had prostaglandin agonists, and we had Rho kinase inhibitor. All these 3 enhancing the drainage or outflow of aqueous humor, leading to reduction in intraocular pressure. Okay. Now let's talk about. Okay, so also we have still something on netrosudil. Sorry. So the most common adverse effect associated with netrosudil is conjunctival hyperemia, and other adverse effects are like installation site pain, erythema, corneal staining, blurred vision, lacrimation, eyelid erythema, reduced visual acuity. Okay. So now let's talk about drugs which reduce the synthesis of aqueous humor. Okay. And the most important category here is beta blockers. And we have timolol, which is the most commonly used. We have levobinolol, and it's long acting. So that's why it's used once daily. Then we have metipranolol, cartiolol. If you don't want to remember their names, it's okay. The metipranolol, cartiolol. These 2 names, if you don't want to remember, it's okay. And betaxolol. But you need to know timolol, levobinolol, and betaxolol. Okay. Betaxolol is selective beta-1 agonist. Oh, sorry, antagonist. So these are beta blockers. So selective beta-1 blocker. While timolol is not selective. So these drugs competitively block beta-adrenergic receptors, and they lower intraocular pressure by decreasing aqueous production while blocking beta receptors. And in the beginning we spoke that like the stimulation of beta-1 and beta-2 will increase the synthesis of aqueous humor. So if you block them, the production of aqueous will go down, and that will lead to lowering of the intraocular pressure. They have little effect on pupil size. Why? Any idea?
They're competitive inhibitors.
Okay, which receptors are alpha or beta on the pupil?
I think they were alpha, if I'm not mistaken. I'm not sure. I don't remember.
Yeah, so they are alpha, and that's why the beta blockers have little effect on pupil size. And when you use them, the maximum intraocular pressure reduction is of 20 to 30%. So they lead to 20 to 30% reduction in the intraocular pressure. Okay. Tolerance develops over a period of few weeks. Again, as you probably know from your POD, that beta blockers are notorious for developing tolerance. So you need to increase the dose after some time. You know what is tolerance, huh?
Yes.
Okay. What is it?
Tolerance is when, after a period of time, the body gets, for lack of better terms, gets used to the amount of drug given. So the next time for you to get the same effect, you need to administer more of the drug.
And how body gets used to it?
What happens is there's downregulation of the receptors.
Yeah, so either downregulation or upregulation. Depends if you're giving a beta blocker. If you're giving an antagonist, then there will be upregulation for tolerance. Okay.
Yes.
If you're giving an agonist, then there will be downregulation for tolerance. Is that clear?
Yes, very clear.
So adverse effects of beta blockers, we have local effects like burning sensation, hyperemia, corneal anesthesia, dry eye, visual disturbance, and you have systemic effects. Now they can get absorbed systemically, and because they are not going through the first pass metabolism, so they can have some serious systemic effects as well sometimes, and especially in susceptible individuals. So what sort of systemic effects do you expect?
Bradycardia?
Yes, very good, bradycardia. And if you're using non-selective, then what about lungs?
Bronchial constriction.
Yes. So cardiovascular, you have bradycardia, heart failure, hypertension, and pulmonary airway obstruction. Okay, bronchoconstriction. Good. So again, and that means you don't want to use them in people who have already bradycardia, or AV block, or heart failure, or those who have asthma. You don't want to use them in them. Okay. So contraindications would be somebody suffering from, for example, bronchial asthma, or COPD, or bradycardia. Okay. A severe heart block. Okay. So the other category of drugs reducing the production of aqueous humor would be alpha-2 agonists. So alpha-2 agonists, why? Okay, we have two alpha-2 agonists, apraclonidine and brimonidine. So can you explain how the alpha-2 agonists, again, these are supposedly like sympathetic nervous system? Hello. So shouldn't they increase the production rather than decreasing the production?
Yes, they
Maybe
should.
maybe they do the vasoconstriction of the blood vessel near to the secretion of the aqueous humor.
Okay.
So by that maybe we decrease the secretion of aqueous humor. And then
Alpha-2 limits production of alpha-1.
Sorry?
The alpha-2 receptors on the postganglionic, they reduce the production of alpha-1.
Not post,
Presynaptic, sorry, yeah.
Pre-ganglionic, yes. Very good. So those effects which we like when we speak about sympathetic effects, those are alpha-1, which are on the postsynaptic neuron or organ. So which produce those adrenergic effects. But the alpha-2 are present on the presynaptic ganglion. They are for the negative feedback. So the catecholamines which are in the synaptic cleft, they stimulate these presynaptic alpha-2 receptors as a negative feedback, and once they are stimulated, they decrease the production and synthesis and release of epinephrine and norepinephrine from presynaptic. So stimulation of alpha-2 agonists, though they are supposed to be sympathetic receptors, but their stimulation is practically sympatholytic, same as we are doing beta blockers. Is that clear?
Yes.
Yeah, good. So by stimulating presynaptic alpha-2 receptors, these drugs will decrease the production of catecholamines. So in practice, it will lead to sympatholytic effect, same as we have effect with the beta blockers. So these two drugs, the primary action is decreasing aqueous production. So the primary action is decrease aqueous production. They have secondary action as well, which is not mentioned here. They have a secondary role in the drainage as well, which I will not go into those details because then it will complicate the situation. But they have a secondary role. But here we are talking about them as they reduce the production of aqueous humor and maximum intraocular pressure reduction of 20 to 30%. Their adverse effects are lid crusting. So they are also commonly used, and especially in combination, both in acute angle as well as opening. So lid crusting, burning and stinging sensation, ocular hyperemia, headache, blurring. So these are the adverse effects. Their contraindications would be again hypersensitivity, cardiac disease with untreated AV block, and bradycardia. Okay. Okay, so now this is another drug, another class of the drugs, carbonic anhydrase inhibitors. Here we have both types. We have topical as well as system. So far we were talking about topical drugs. Okay. Now carbonic anhydrase inhibitors. Now this is an enzyme. This is not acting on any receptor. Okay. So carbonic anhydrase inhibitor, anhydrase enzyme itself, it's involved in the production of aqueous humor by causing bicarbonate and hydrogen movement. So bicarbonate plus hydrogen leading to water and carbon dioxide. So this movement across these two sides of the equation is facilitated by carbonic anhydrase. So inhibition of carbonic anhydrase 2 in the ciliary processes of the eye decreases aqueous humor secretion by slowing the formation of bicarbonate ions with subsequent reduction in sodium and fluid transport. So carbonic anhydrase inhibitor will reduce the aqueous humor production. Okay? Is that clear?
Yes, doctor.
So end result is reduction of aqueous humor formation and subsequent decrease in intraocular pressure. So we have topical carbonic anhydrase inhibitors, dorzolamide, benzolamide, okay? These two, and there are many others as well. Topical carbonic anhydrase inhibitors, okay? The maximum intraocular reduction of 15 to 20% with these drugs. However, okay, let's talk about adverse effects of the topical carbonic anhydrase inhibitors. Bitter taste, stinging, conjunctival hyperemia, tachyphylaxis, and they're contraindicated in patients with sulfur allergies because these are sulfur drugs. They have sulfur moiety in it. So they are contraindicated in people with sulfur allergies. And I hope you know the difference between tachyphylaxis and tolerance. What is tachyphylaxis? Hello. What is tachyphylaxis? It is a rapid development of tolerance. That's tachyphylaxis. So far we're talking about the topical drugs, okay? And the topical carbonic anhydrase inhibitors. But we have systemic carbonic anhydrase inhibitors as well. One of them is acetazolamide. This can be given orally as well as IV. Okay, remember this can be given orally as well as IV. It's a systemic carbonic anhydrase inhibitor. Due to its action on the proximal convoluted tubule, because this is systemic, it will go everywhere, and it has a very important effect on the kidneys. It will lead to sodium retention, alkaline diuresis, so imbalance in the acid-base balance, though tolerance develops against it as well. So obviously there will be lots of side effects. Then why are we talking about this drug? Why do we use this drug? When we have topical ones which have lesser side effects, then why you talk about systemic acetazolamide? Any idea?
Maybe emergency?
Yes, emergencies. The reason is, see, in others, you see the maximum reduction of intraocular pressure was 15 to 20%, 20 to 30%. But this one can reduce intraocular pressures 40 to 60%. So in emergencies, especially with the acute angle closure glaucoma, when the pressure is very high, there's a risk of loss of vision, you start with the IV acetazolamide, and then you give oral acetazolamide, and then you also give topical beta blockers and alpha-2 agonists, and then later on you might give the cholinergic agonists and these things. So that's the main use. So use mostly in emergency because of side effects with chronic use. Adverse effects: metallic taste, paresthesias, kidney stones because of, as I said, acid-base imbalance, so it leads to kidney stone formation. Then we have osmotic agents, mannitol and glycerol. Now, I don't have time, otherwise we would have discussed like how the drugs work. Like, as you know, some drugs work through receptors, other drugs produce some chemical reaction like enzyme inhibition. But then there are other drugs which just work by their mere physical presence. These are those drugs which just act by their physical presence. When they are there, they increase the osmolarity of that solution, and because of the osmotic drag, they work. So these are osmotic agents. They lower intraocular pressure by creating an osmotic gradient so that water is drawn out from the vitreous into the blood. They are employed when a short-term reduction in intraocular pressure is required that cannot be achieved by other means, such as in resistant acute angle closure glaucoma. Okay, so again, this is used after, even if the acetazolamide doesn't work, then probably you'll go to these because they have other side effects, because it will increase the intravascular volume, which will increase the cardiovascular workload. So you have to be cautious in patients with cardiac problems or renal diseases. Okay, so let's just recap very quickly. Treatment of glaucoma, key points. All drugs are directed towards decreasing the intraocular pressure by either by, how do you do that? Hello?
Presence, osmolality.
No, we are done with the osmotic ones. Now we're just recapping the whole lecture.
Oh, so you either increase the absorption of
increase the drainage or outflow. Okay,
yes.
or decrease the production.
Yes.
So either you decrease the production, how? Like with beta blockers, alpha-2 agonists, or carbonic anhydrase inhibitors. Okay, or you increase the outflow with cholinergic agonists, prostaglandins, Rho kinase inhibitors. Can you remember that?
Inshallah.
Okay. Yes. So can you name cholinergic agonists?
Pilocarpine.
Yes, good. Can you name prostaglandins?
latanoprost and
Latanoprost, travoprost, oprost, oprost. Cholinergic agonist, we had pilocarpine, and we have another one, ecothiopate. Okay, what was Rho kinase inhibitor?
metarsudil.
Very good. Can you name beta blockers?
Timolol, betaxolol.
Okay, levobinolol, timolol, betoxolol. Alpha 2 agonists?
Brimodine.
Yeah. And apraclonidine. Onidine. Carbonic anhydrase inhibitor. Can you name the systemic one at least?
Acetazolamide.
Acetazolamide. So zolamides. Good. So again, you need to understand the ANS for their effects in the glaucoma as well as to understand the side effects. I think we are out of time, but I have two cases if you're interested. We have a 48-year-old shopkeeper presented at the eye clinic with a history of gradual painless vision loss. His presenting visual acuity was counting fingers at 1 meter in the right eye and 6/60 in the left eye. Intraocular pressure was 32 millimeters of mercury in the right eye and 30 in the left eye by tonometry. Gonioscopy showed open angles in both eyes. Fundoscopy confirmed the diagnosis of glaucoma. So fundoscopy, we were able to see the optic disc atrophy and cupping of the cupping, and so all those features of glaucoma we were able to see. So it confirmed diagnosis of glaucoma. So what type of glaucoma it is?
Open angle.
Open angle. Wow, like good. Which drugs are available to treat this condition?
Prostaglandins.
Yes, very good. Prostaglandins, beta blockers, alpha 2 agonists. So good. So first thing we start with prostaglandins. Very good. And there are surgical options. I won't go into those because I think ophthalmologists will cover that. Second scenario: 64-year-old woman presents to the ER with severe pain around her right eye for 4-hour duration, accompanied by blurred vision in that eye. She is also nauseated. Examination showed a red right eye with edematous cornea, a wide pupil that is unresponsive to light. So it may be unresponsive to light or sluggish to light. Intraocular pressure was found to be 60 millimeters of mercury only in the right eye. The anterior chamber angle is closed in both eyes. So anatomy is abnormal in both eyes, but the acutely raised pressure is in the right eye. Okay. So here we have problem in the right eye. So what is it? Which type of glaucoma is it?
Acute angle?
Yeah, acute angle closure glaucoma.
Close up.
So it's angle closure glaucoma and it's acute. There is a chronic form as well. So this is acute angle closure glaucoma or acute closed angle glaucoma. Okay. And how would you treat it? Like you need to reduce the pressure rapidly because otherwise this person may lose his vision. So how would you do that?
Do we give acetazolamide?
Yes. So you will start with the IV acetazolamide. First dose IV acetazolamide, probably then you might give oral acetazolamide. At the same time, you can start with topical drops of, say, for example, timolol, and so beta blocker, alpha 2 agonist like apraclonidine. And once the pressure is below 40, then you can add pilocarpine. Before that, pilocarpine probably won't work because the iris is kind of stuck on the pupil, and pilocarpine is not able to do any meiosis or anything like that. So it may even harm instead of giving any benefit. So you start pilocarpine drops after it comes below 40. Okay. So the first thing would be acetazolamide, timolol, beta blockers, alpha 2 agonists like apraclonidine, and then later you can add probably 1 hour later or 30 minutes later pilocarpine as well. And if these things doesn't work, then obviously you can go on to surgical options as well. And eventually, once the pressure is normalized, these patients have to be referred to surgery, like either laser therapy or surgical intervention. Okay. Okay. So that ends the case. But one thing I want to discuss with you guys, if you can stay with me just for 5 more minutes. Are you there?
Yes,
Yeah.
This is important because see, assessment we do, one thing is to grade you. The number 2, we need to know like what like, is there any problem in teaching, or is there some important concept which has not been delivered properly? So what happened? Remember, we had a lecture on opioids.
Yes.
And we did some review in the therapeutic session as well. And one question that, like, I put many questions. The other questions you guys did well, but one question where I put as, for myself, I made it very easy, that there was a scenario of opioid withdrawal. And I asked the drug that you would give, how would that work? And a good number, like most of you did it right, but good number of you also did it wrong. And the problem was in the interpretation of the scenario. So you need to differentiate between opioid withdrawal versus opioid toxicity. Are you listening?
Yes.
Yeah. So, like, was there any problem in that one? You remember that question where there was a mu agonist and mu antagonist in the options?
Yes, doctor.
Yeah. So a heroin addict can be in the withdrawal as well. He can be in the toxicity as well. If you overdose, so he can be present with overdose toxicity of opioids. Okay. So that presentation will be different versus someone who is heroin addict but is not able to get heroin due to some reason. Suppose he is in a lockup or in a hospital. So he might go into withdrawal. So symptoms of withdrawal will be different. And there is a slide where I have shown the both effects side by side. So that is very important that you revise that. So you should be able to differentiate. So actually that scenario was opioid withdrawal. And so I try to make it easy, because if I put the names of drugs, so then there can be confusion whether I want to treat the addiction or I want to treat the withdrawal. So whether it would be methadone or any like morphine or anything. So to avoid that confusion, I just put the receptors. So mu agonist, whether it's a methadone, whether it's morphine, whether it's heroin, all of these are mu agonists. So you give anything, his symptoms will be taken care of. He'll be treated. Is that clear?
Doctor?
Yes.
I have a question. Can I ask?
Yes, yes.
Okay, so could you repeat why do beta blockers have little effect on the size of the pupil?
Sorry, beta blocker?
Yeah.
Can you repeat the question?
Why do they have little effect on pupil size?
Because we have alpha receptors over there, not the beta receptors.
Oh, okay.
So that's all.
Okay, thank you.
Okay, any other questions?
Yeah, doctor, for the osmotic drugs, you said that both of them only act by they don't act chemically neither on a receptor. They act only by their presence.
Yeah, physical presence. They are like they increase they are increasing the osmolarity of the solution. So because of the osmotic drag, water gets pulled.
Okay.
So when you're giving them IV and when they are in your intravascular compartment, so intravascular compartment would want to increase the volume to decrease the osmolarity. So it will pull the water from every space. So it will, so even from the vitreous, so there will be pull on the water from there. So pressure in the vitreous will go down because of that.
Okay, thank you. And for the alpha-2 agonist, I don't understand how they act, their mechanism of action.
Yeah, alpha-2 agonists, see if you look at the presynaptic and postsynaptic neurons, do you understand that part?
Yes.
So we have preganglionic fibers and then we postganglionic. So when they synapse, so the alpha-2 receptors are present on the presynaptic neurons as a feedback loop. Like whenever you have production of any neurotransmitter or hormone, anything, it will go back and inhibit its production. That's negative feedback. Just a minute. I just want to open something. Yeah. So here the catecholamines inhibit their production by stimulating alpha-2 receptors which are present on the presynaptic neuron. So stimulation of the alpha-2 receptors will inhibit the more production of catecholamines from those neurons. So it will overall will reduce the sympathetic output. So stimulation of alpha-2 receptors will reduce the sympathetic output. Is that clear? Or no?
Yes. Yes, yes. Thank you so much.
Yeah. So again, I just wanted to summarize these drugs. So overall beta blocker, so we are reducing the sympathetic effect. Alpha-2 adrenergic agonist, it will reduce the sympathetic outflow, so it will again will be less sympathetic. So the net effect will be similar. So beta blocker and alpha-2 adrenergic agonist will have similar effect. Okay. Though one is blocker, the other one is agonist, but in the end, this alpha-2 adrenergic agonist also will lead to decreased sympathetic output, so will lead to reduced aqueous humor production.
Doctor?
Yes.
Doctor, in clinical scenario, in the second clinical scenario,
Sorry, yes.
You said we give the patient pill-carpine once the pressure becomes 40, or like
less than 40, yes.
Less than 40. Why is that? Could you repeat that, please?
Yeah, because even above 40, now see, this is not a hard and fast rule that it has to be 40 exactly. But generally, when the pressure is very high, so the iris is, see, pupil is fixed and mid-dilated. They say non-reactive because the iris is not able to contract and cause like induce meiosis or meiosis. So when you shine light, there's no meiosis because the iris is not able to move. The pupil is fixed. Now the pilocarpine is supposed to cause meiosis, but if it is so much fixed against the lens, then the pilocarpine will not work.
Okay, I get it now.
See in its effects, so it has two effects. So in the acute situation, it works by causing meiosis and opening the angle. But if it is fixed, it's not able to move, so it may not be able to open the angle immediately at that very high pressure. So once the pressure comes down, then the iris muscles have enough space to do their movement and open the angle and cause the meiosis. Okay.
Okay, thank you, doctor.
Any other questions? So this time, because well, like from experience with you in neuro, you did well in questions which were like very direct and recall questions. But the questions which were more mechanistic and conceptual, the performance was literally not that good. So try to memorize things this time, because now so based on your performance, so this time I've tried to put things which are more direct and recall.
Thank you, doctor.
Okay, so best of luck for your exams and happy Eid in advance. Have a good time. Massalam.
Thank you. Happy